conference has been muted.
Hi, good afternoon, everyone. Welcome to today's webinar session entitled Leading Change, Embedding Nursing Order Sets in EPIC, presented by Barb Chapman. Chapman is a registered nurse with many years of clinical experience in program and project management in hospital settings and health system networks. She holds a BSCN in nursing and a master's in e-health. Under her employment at St. Joe's Healthcare in Hamilton, she applies her knowledge and experience in her role as a clinical informatics manager, leading special projects and integration. That this webinar will be recorded, and today's participants will receive an email with instructions on how to access the recorded link, which will be saved and posted on the RNAO website and the health communities of practice. At the time, all participants are in listening mode and automatically muted for the presentation portion of the session. There will be an opportunity to ask questions at the end, and there are two ways to do so. The first option is to type your question into the chat box on your screen, and the second option is to unmute your line by pressing 7 and ask a question verbally. We will also be doing a formal evaluation survey at the end of the presentation, and we kindly ask that you stay until the end of the presentation and complete the short 6 questions. Then I'll turn it over to Barb to begin. And Barb, just a friendly reminder to unmute your line by pressing *7.
Thank you so much for that great introduction. Good afternoon, everybody. Thank you for joining us. And as Tanya indicated, my name is Barb Chapman. I work at St. Joe's Healthcare in Hamilton, and we have the opportunity to be able to be involved in this initiative with the RNAO. The object for our presentation today is to walk through the process on how we design integration of the RNAO ICNP encoded nursing order sets into EPIC Care ambulatory application. This was to support best practice, document the best practices, and allow for data extraction so we could examine the quality of care and patient outcomes. I want to say a special thanks to those that were involved in this project. Special thanks to Canada Health InfoWay for funding this initiative, and for the RNAO for all of their great support, the project sponsorship, and ongoing support. Been a great leader in this project. Including the RNAO, there was an established peer leader network in January of 2016. This is part of the Canada Health InfoWay Clinician Peer Network initiative, and if you'd like information about the Canada Health InfoWay Clinician Peer Network, please feel free to check out their website. There's a lot of exciting new information about that on their website. So over a year ago, the RNAO recruited the nurse peer leaders to participate in this initiative. They've launched a request for proposal, and many organizations across the province responded to this request for proposal, and St. Joe's was fortunate to be one of the 4 organizations that were awarded the opportunity to participate in this project. A little bit of information about St. Joe's. We're an 100-bed academic health center, home to more than 4,000 staff, 700 physicians, and 600 volunteers. St. Joe's is a multi-site organization. We provide regional and tertiary care, and we're renowned in our stress and respiratory care, kidney and urinary care, mental health and addictions, services, cancer surgery, and women and infants care. The departments of the kidney urinary, the regional kidney urinary program, volunteered to participate in this initiative with clinical informatics. The department provides care to patients with chronic kidney disease across their care continuum, and patients with chronic care disease also have diabetes. It was identified that this program would be an ideal setting for implementing the assessment and management of foot ulcers for people with diabetes, order set. Nephrology program includes nephrology, dialysis, and renal transplant. And this program sees about 1,000 patients per year. 51% of those patients have diabetes, and 5% of patients with diabetes also have a history of foot ulcers. So RNAO, or nursing order set, it's a tool that translates the best practice guidelines into a format that can be used in an electronic information system, or it can also be used as a paper-based tool guide practice. Content for clinical decision-making, supports logic to trigger interventions based on specific parameters, and rates alerts, reminders to enhance patient, client, resident safety, and aid decision-making at the point of care. So when I get further into the presentation, I'll elaborate a little bit more about triggers and parameters. So St. Joe's, as I said earlier when I discussed the background of our organization, it was decided that we would adopt the assessment and management of foot ulcers for people with diabetes, and also the best practice guideline for strategies to support some management in chronic conditions, collaborating with clients. So how it started was first we brought together a steering committee. So we took our organization sponsor, who is also our professional practice leader and acting director of nursing, senior program manager, nurse manager, and then myself as the nurse peer leader. We worked together at the beginning to talk about the scope of the project, the expectation of the projects, and resources that would be involved in the project. Developed our project charter. The steering committee then sent invitations to members of the implementation team. Implementation team, myself as the clinical informatics manager, a peer leader, one of the members of my clinical informatics specialist team, our educator, primary care nurse in the nephrology program, nurse practitioner, who is one of our wound care practitioners, an informatics trainer, and communication and technology analyst. The clinical team started to assess the nursing order set. The order set is broken down into multiple components, as well as the nursing process, assessment, planning, implementation, and evaluation. And associated nursing order sets are, so in the order set are associated documents and alerts. So we have flexibility of choosing documents that are best practice. So there's different classification systems. So we looked at our policy and what within our organization to leverage what was already in place, as well as aligned with the nursing order set. And started after we were familiar with the contents of the nursing order set, then we started to design how we would embed the nurse set into the system. Off with developing some clinical scenarios, working through some process formats to help us organize information in a log format, also in a make sure that the system was to document in the system, that we didn't have any duplication, that we reduced keystrokes, ensuring that the nurse only had to document what was applicable. So before we go on, I just wanted to mention that as how we integrated the nursing order sets, I would like to say that I'm unable to share any screenshots or details of the build at this time. What I'm sharing are concepts on the way the information is managed and how this would support nursing practice in the assessment and management of foot ulcers in people with diabetes. If there is anyone on the call who is a customer of Epics and would like to reach us, if at the time that they're planning on inputting this into their electronic medical record, we'd be more than happy to with you, but I cannot present any Epic-specific material at this presentation. Saying we did the flows, Tanya, mind just popping back to the flow? Thanks. So once we did the flows, so we looked at patient comes in for a clinic visit. They come in for regular clinic visits, and at the time they come into the clinic visit, they would identify that they are diabetic. They would assess any concerns that patient may have with their feet, and also assess risk factors. And they do that initial screen. Based on what they found in that initial screen, that drives the next phase of information that they were required to gather as they're continuing on this care path with the patient. What you see here is just the assessment part of the flow. It's, as you can imagine, the flow is quite easy and very difficult to display. So I just gave you a snapshot. Even though this is a little difficult to view, I will go into a little more detail as we go on. So now the next slide. So something leveraged in our system is NOMED CT codes. And we needed to do this early on in our design to map the ICMP concepts to the SNOMED codes, because it was part of the, it was required in the build design process in order to enable the data extraction. So the application does not contain the ICMP concepts, but it does contain the SNOMED standards for health terminology. The exercise where we reviewed the how ICMP codes are mapped to SNOMED CT. So we leveraged the information that was already in our foundation system. The international so how to trying to get the full name, but the organization for the ICMP codes have done the work in mapping all the ICMP concepts to the SNOMED terms. So we're providing information to help us with this exercise. So we had mapped all the ICMP codes to the SNOMED terms, identified all the values in those data elements. So organizing them in the table by the child elements and then the values within those elements. And this was to enable the data extraction, organize the information, and enable the data extraction. So the actual entering of information during a patient assessment identifies the patient risk factors. And as they're identifying the risk factors, they would select which risk factor was applicable and whether the patient had a current ulcer. It was set up so that you could do baseline assessment, which was the initial assessment where there was a concern, where there was a foot ulcer, or you could do follow-up assessments. So the system, it allowed to be full in identifying whether we were starting off with a baseline assessment or a follow-up assessment. So in the case with this clinical scenario, we've identified that the patient has a current ulcer, impaired circulation, and they have some behavior and knowledge deficits. So we select those three concerns, that the open up or expand those ways of assessment. So assessing the current ulcer, assessing the circulation, the last one should be assessing self-care knowledge deficit. Can you go back, please? Thanks. So you see the ones that I grayed out on the far left side were not selected. So any associated information that would be documented against those risk factors would even appear to the nurse in the system. They would be hidden because they're not applicable. So then once the assessment has been completed, then the system to be able to take us directly to the treatment plan. And the assessment will trigger us to select the appropriate treatments required for this patient. So during that time with caring for the patient, interaction with the patient, you would be the nurse would be plan with the patient and then identifying what those interventions are. So this patient would have treatments, referrals, follow-up, and education. So patients in a nephrology clinic have frequent over time, and in order to assess which visit and have that documentation, so we could view their response to treatment. We want a flow sheet that would give us that summary of change from visit to visit. So this is kind of a conceptual view of what that summary would look like, starting off with the assessments and then showing the values of the data that was entered on each visit with that patient. And then from there, we also wanted to see if we could have tools that would also provide the nurse with a view of time. So Tanya, if you could pop to the next one, please. Thank you. So that was from the flow sheet. We wanted that to come into a summary so that we were able to trend healing. So synopsis from the flow sheet would enable all the trending of all the attributes. As a tool would display as a graph show that this patient is healing well. We're using the push score, which is one of the tools that is recommended in the nursing order set. So the values that are generated from the wound size, IC date, and tissue type would draw a score that gives a push score, and that we'd be able to trend that, and that gives us an indicator of how the foot ulcer is healing. The efficiency we wanted to be able to have in the system was to, if a patient required a referral, rather than write a referral form and faxing it off to the health service provider, whether it be CCAC or a chiropodist or a podiatrist, we want to be able to make the process more efficient. So the system allows us to create a template, and when the nurse has a decision to refer the patient for care, click on that referral, and the referral template would open up, and in that document that pulled data from the patient into a referral letter, and then the referral letter is faxed to the service provider organization. And this added feature too will also, we can monitor it and ensure that the referral letter is reaching its destination. So many efficiencies found in that process. The data extraction plan. So there are a number of issues that we are required to report to NCORT. And what this table shows you is each column, or the all of the indicators. And we had mapped all of the ICNP codes to NOMED codes, and then we grouped all the values associated with each NOMED code. They were able to provide instructions to our information communication and technology analysts on how to extract the data. So first step was to use the SNOMED code for diabetes, just to capture data on all patients with diabetes. And the query is very much the way, if you're familiar with the way query tables are set up in SPSS, you define what is being included in your query from each of the data tables. So then we identified, once the ICT analyst wrote the code to identify all patients with diabetes, and then she was able to all patients that had a bilateral foot assessment by selecting the that the exam was normal, abnormal, or amputated, so that indicated that the patient had their examined, and then aligned all patients that had a foot assessment with a foot ulcer, used the SNOMED code, and found all patients where the equaled yes. Then the patient, the foot ulcer would be, the patients with a foot ulcer would be included in the analysis. And then you get how the queries were created in the point where we're extracting the data and auditing the data. We're looking at of the tool, and we're putting some processes in place to increase our adoption. And we're looking forward to ongoing analysis of the data to see how this initiative has improved practice and improved outcomes. Summary, just some key points that I want to highlight is a dedicated team is vital for this. It's really hard to do projects at the side of your desk, so having dedicated team, dedicated time is vital. Having a very clear project charter, scope of the project, as it's very easy for your project to get than what it was initially intended to do at the beginning. Member project team need to be influential champions. This team was really well recognized for their expertise in this area, and we're very enthusiastic about being involved with this project. During the project, you're involved. Your subject matter experts informing on the project, right from the initiation, the planning, through the design, the validation, and the implementation. The whole team was involved with our education sessions, educator providing that background on where our private nurse providing the background on the context of the clinical areas and how the practices would be adopted in the clinical areas. Our trainer was involved with that would be using the system, how to navigate through the system, and how to use the tools that were built for them. Now, post-implementation, we're in the process of getting our data and opportunities for process improvement, for adoption improvement, and as I say, looking forward to looking at the impact on patient outcomes. I just want to open up the lines to see if there are any questions, or you can also type questions into on the webinar. Tam, if you want to open it up for questions, that'd be great. Thank you.
There's one question that someone just typed in, and the question is, what was the timeline for this project?
The nurse peer leaders met together as a group in January of 2016 and orientated to the project, to the objectives and the milestones in the project. We, as peer leader, had 1 week allocated to the project. So I can just give you a sense of kind of our timeline. And there was other pieces of the project. There was our e-services, which were tools for patient self-management that we were working on in parallel with this part of the project. So a lot of it is we met a couple of times with our nurse peer leaders at the RNAO and planned out the project, and then engaged our steering committee and developed a project charter and invites to our subject matter experts to be part of the team. They started designing in probably about March, doing flows designing how we were going to the system, what we're going to include in the system, and then started building, I would believe, in about June. Project matter experts back together to validate the system in July, August, and we implemented in September, October. The other organizations that are involved in the project were implemented in September. We were more into the mid to end of October. Answer your question?
Question on mute.
There's another question. The question is, any challenges that you have faced with the software?
No. No, I really love the system. It's very nimble, it's very flexible, it's very, has a lot of great tools in it. You can build logic in. And don't underestimate the work that our clinical application specialists put into building it. The key is spending a lot of time in planning and designing how you want to build it into the system. It's not something you want to tackle when you're this builder. You definitely need to have a good experience in the system to be able to build out the functions.
Are there any questions at this time? Reminder to unmute your lines by pressing *7. Oh, there's one other question. The question is, any challenges in general that you can think of?
Adoption has been a challenge. We have a unique situation where we're still in a bit of a hybrid system with our program, that there's screening is done in one system, and then the referral to care nurse. When they pick up the referral, then they have to document in a different system. So they have to document in Epic once that referral is made. So we're working through some of the adoption challenges right now, and as I know, in the future, we want to be able to look at the impact on outcomes. So we're still using our data to identify those flags where we have concerns with adoption, and work through some process redesign, and continue to do some of that work with process redesign to adoption.
Question, and the question is this going to be easily replicable by other organizations who use or plan to use Epic?
Absolutely. That's what I say. I'm not at liberty to share some of the detailed build and screen of the system, but Epic has this great community of practice where organizations can showcase their successes and share with organizations. And if you're a customer of Epic's, you can reach out through this community of practice and support each other in ideas and build and different types of integrating functionality in the system.
Time we will do the short evaluation. So I'm going to open up the poll, and if you could just take a few minutes to answer the questions to the right of your screen, that would be greatly appreciated.
So thank you very much to everybody that attended this presentation, and feel free to reach out to me at St. Joe's. Thanks.
But we're just going to remind everybody that there is another, there's an in-person workshop happening on May 24th in Toronto, and the workshop will be focusing on implementing the nursing order set. So if you're looking for more information on that, you can feel free to contact Tanya Costa, and my email address is tcosta@rnao.org. And again, the workshop is on May 24th. It's an implementation workshop focusing on the nursing order set. And I'd like to thank everybody for attending today, and thank you, Barb, for your great presentation.
Thanks, Tanya. Have a good day.
You too.